Hello, good evening, everyone, and welcome to 365 Live. I'm Bina, and I will be your host for tonight's session. This is a gentle reminder that all information shared at this event by the speaker and 365 CPS is for general information only. Please consult your doctor for personalized and detailed medical advice. Without further ado, I'm pleased to introduce tonight's speaker, Dr. Brendan Chia, radiation oncologist at Raffles Cancer Center. He was formerly a consultant at National Cancer Centre Singapore. He led neuro-oncology radiation, championed patient screening, and taught at Duke NUS. A dedicated educator and Singapore Radiological Society member, Dr. Chia excels in advanced radiotherapy, enhancing outcomes and promoting early detection to reduce cancer mortality. He's here tonight to talk about cancer screenings and to shed light on the various screening methods. We will explore their differences and debunk common myths and misconceptions surrounding screenings. If you have any questions, please feel free to post them in the chat and Dr. Chia will address your questions during the Q&A session. Hi, Dr. Chia. Thank you very much for joining us tonight to share your knowledge with everyone. Like our audience today, I'm very interested in finding out which cancers I should be screening for and how often should I do so. Let me hand over the time to you now. Dr. Chia, please.
Good evening, everyone. Thank you for joining. My name is Dr. Brendan Chia, and I'm from Raffles Hospital, and it's an honor and pleasure to be able to present this talk to you. So, without further ado, let me continue. So today we're going to learn about cancer screening and why it's important. Cancer is a big challenge in Singapore. From the Cancer Registry report, we know that 1 in 4 people will actually develop cancer before the age of 75. And it's the principal cause of death in Singapore of 1 in 4 as well. So 25% of the population will actually face the eventuality of death because of the cancer. So it's something we really need to tackle, especially in Singapore. The top most frequent cancers depends on whether you are male or female, but the top 3 or top 5 cancers overall in both sexes is the colorectal, the breast, the lung, the prostate, and the liver cancers. Well, there's a growing concern that cancer is on the rise and is increasingly affecting younger patients. It's affecting everyone. So across all age groups in Singapore, the rates of cancer are increasing. But especially in the young, where we don't expect young patients less than 50 years old to get develop cancer, or as a doctor, most of the time when you see a young patient with some chronic symptom or chronic pain or things like that, we wouldn't think firsthand, oh, it's cancer, it's something. We will think more of a muscular pain or something. But increasingly, we see a rate of incremental increase, especially in the younger age groups, less than 50 years old, where the rates of cancer are actually rising in this group. In Singapore, the story is especially so for the female population as well. And there was an article recently in last year, December, about more cancer patients in Singapore die as compared to the US or in South Korea. And this was published in the Straits Times. And a large part of it is probably due to the age diagnosis, where patients are actually diagnosed later in Singapore. And there's a lower screening rate in Singapore as compared to the other developed nations. Most cancers in Singapore are diagnosed at the late stage. And when it's at the late stage, that means when it's spread or the tumor is very big, it portends a poorer outcome for these patients with a poorer chance of control and cure for the patients. As you can see in the statistics, this was published by the Health Promotion Board and the Ministry of Health. It's a registry data, especially for certain cancers like the prostate, the colorectal, the lung, the stomach, the pancreas. These cancers actually present at the later stage, where they are in the stage 3. A majority of the patients are stage 3 or stage 4, right? And what significance does that make? Is compared to the 80-90% cure rates which you can get in the earlier cancers, those with a later stage of diagnosis, actually the cure rates are about 10% or lower. So what are the ways to reduce your cancer risk? There are many ways, such as healthy lifestyle, going for your vaccinations, being physically active, and one key thing that we can do is to take part in cancer screening programs, right? And then that way we can prevent 1 in 3 cancers. What is the screening uptake like in Singapore? What's the purpose of this? Do we have a very good screening uptake? Actually, to be honest with you, in the population-based survey that was done and published, less than half of the respondents actually had gone that were actually supposed to go through screening had ever gone through screening. For example, in terms of cervical cancer, pap smears, and or HPV testing, less than half of them had ever go through even one screening. For breast cancer, mammograms and stuff, about a third actually went through screening. And the worst, and it's even worse for the colorectal cancers. And one of the key things is that there are many barriers with screening, such as being unaware of the cancer prevalence, or the patients generally feel fine. They say they eat regularly, they exercise, so they don't need to go for screening, or there's no family history of screening. There's also other misconceptions, such as screening is unnecessary, the tests are costly, screening is painful, the screening causes cancer. You do it one time a year, and that's it for the rest of your life, and that's enough. That's also a common misconception that, oh, I did my screening 5 years ago, so I didn't do it again. Right? Other people do not have, sometimes the patients don't place priorities in screening, and they feel that, oh, they don't have time to screen. They'll keep postponing it even though it's due for screening already. And sometimes patients are, rightly so, they are scared to receive any bad news, or they don't want to burden the family, or there may be other cultural, religious, or personal beliefs, right? But ultimately, screening is your choice. There are guidelines available as to who should get screening. There are doctors who do encourage screening, but ultimately, it's your choice, and for you to be informed and for you to share the information with your friends, your relatives, and close ones, that screening actually saves lives from cancer. You can detect cancer at an early age, and it can prevent cancer from developing as well. Of course, there are some risks, and there are also misconceptions, and that's why I'm happy to share with you further on. So, what are the Singapore national guidelines for screening for the average risk population? That means the general population, the people without any family history, without certain risk factors, right? So, this is published in the Ministry of Health website. For in both men and women, colorectal screening should be done at the age of 50 onwards, and that colorectal screening can be done through either a colonoscopy or through the yearly fecal occult blood test, right, or the yearly FIT test. For women, there's 2 additional screening tests that are recommended by the Ministry of Health. One being the cervical smear, for cervical test. If it's a pap smear, it's 3 years. It's a HPV test every 5 years, and that's from the age of 25. And for breast cancers, from the age of uh, in certain risk groups from the age of 40, and for the general public in the age of 50, a mammogram should be done once every year or every 2 years. So why do we want to do screening? Okay, we have lots of evidence, and I'm here to share with you the 2 most common cancers that are that are inflicting our population in Singapore: the colorectal as well as the lung cancer, right, which are the commonest causes of death as well. So in terms of screening colorectal cancers, the stage at which a patient is diagnosed significantly affects the survival. So if I can show you this case here, this graph on the right, the graph being the brown being the stage 4, and the blue and the green being the earlier stages, right? The lower the graph goes, the worse is the survival, right? The dotted line represents the non-screen, and the darkened line represents the full screen, the screen patients, right? So when you are stage 4 and you're not screened, your survival is actually much worse, where at 1.5 years, 50% of the patients with diagnosis at stage 4 would have passed on. But if you actually did screening, it is actually later on. And even better so for the earlier stages, before it's spread or anything like that, the survival is significantly different. So there is a survival advantage to screening and survival advantage when it's detected earlier. So when we start screening, we can see here in this table here that 43% of the people will actually be screened with a stage 1 diagnosis, whereas in the non-screen detected, 50% or more than 50% would either be stage 3 and 4. So screening doesn't just pick up cancers. Colon cancer is actually a stage-wise development into cancer. It starts from a polyp most of the time, and then it accumulates different mutations in the polyp to eventually become a cancer. So colorectal screening can pick up polyps as well, but if the polyp is removed, it's precancerous, it can actually prevent cancer from forming as well. So the average lifetime risk of colorectal cancer is around 5%. So in Singapore, we would say that patients who do not have a family history of cancer should start colorectal cancer and are asymptomatic. That means they have no symptoms of changes in bowel habit, no abdominal pain, no blood in the stools, things like that. Well, the recommended screening for these patients is to start at the age of 50 years old, and you can do so by the yearly fecal immunochemical test that it looks for blood in the stool. Right? The sensitivity is not 100%. So if you do have symptoms, you should seek further advice. But the sensitivity is about 70 to 80%. That means out of patients with cancers in the colon, if you do the test, only about 70 to 80% will be picked up. There are also some false positives. For example, if you have a bleeding pulse or hemorrhoids, that can cause a false positive test. And when you do the test, it's from your stool, it's collected, and it's then returned to the clinic. If you wait and you sort of say, okay, I'll send it to the clinic next week or tomorrow, it actually declines in terms of sensitivity and doesn't become so good. And anyone with a false positive result should then go on to a colonoscopy or a scope where the surgeon or the gastroenterologist will put like a camera into the colon to look out for all these um, bleeding areas or why you actually have a positive test. The gold standard which we should follow is actually the colonoscope that's done every 5 yearly, and it also picks up precancerous lesions like the polyp. CEA, which is the protein blood test, is actually not recommended because it's a very low sensitivity, although it has a higher specificity. So it's not recommended to be done alone for screening as well. Well, there is an increasing prevalence in the younger age groups, and that has led to an adoption of earlier screening in different countries, such as in Taiwan, America, Japan, where they start screening at even the age of 40 years old. Right? Well, in Singapore, although on this online survey by Cancer Society, although 80% believe in the screening, they do not, you know, uh, they are not aware of the recommendations, the guideline recommendations, and even if they are aware, only one in five of them will actually comply with the guideline recommendations. Whereas in the US, where patients are detected earlier or they have better survivals because they are detected earlier, 70% of the adults actually follow the screening guidelines. Sorry, the next we move on is to breast cancer. Breast cancer is actually very significant in Singapore. It's the top cancer, female cancer in Singapore. And interestingly as well, the incidence in Singapore is actually one of the highest in Asia for breast cancer. If you can look here, Singapore's right at the top, and followed by Japan and Korea. Okay, I no specific reason why this is the case as well. Right, and the rates are actually increasing in terms of breast cancer as well in Singapore. So what should you do for females here? You should do screening. So how is screening done? The lifetime average risk of a female in Singapore is about 12-13% for developing breast cancer. Right, so it's recommended that at the age of 50, females should start doing breast self-examinations. How do they do that? They can check YouTube videos. They can look at the Cancer Society and multiple websites how you should feel your breast to make sure that you don't feel for any lumps or any bleeding from your or changes in the skin or any discharge from your nipples or blood from your nipples, things like that. right? From the age of 50 onwards, that's when you should actually start doing a mammogram every 2 yearly up to the age of 70. For certain age groups of patients where maybe there's a family history of cancer, uh, you know, or there was some lumps previously you felt in your breast, you can do a mammogram earlier at the age of 40, right? Although it's important to note that 1 in 4 cancer patients, breast cancer patients, are actually not able to be detected through mammogram, and this is especially the case in younger patients as well. There are also issues with some false positive results with mammogram as well, leading to some overdiagnosis or wrong procedures. Because a mammogram itself just picks up shadows, and from that shadows, you actually need to confirm the diagnosis of cancer by a biopsy or so. There are other imaging techniques available, as well as some innovative blood tests that can be done as well. Right? So we spoke about the mammogram. We also know there's something called 3D mammogram where you can increase the detection rate and decrease the false positive rates. There's also MRI, but the only issue of MRI is actually the availability and the cost. But it is strongly recommended for high risk groups. That means patients with genetic mutations. They may need to do a mammogram at the age of 25, things like that. Yeah. Ultrasound is done sometimes for screening, especially in the younger age groups, but it's important to note where you do it because it can result in a high false positive, right? Blood markers such as CA15-3 or CA27-29 is actually a prognostic marker, and it's used when a patient is diagnosed with cancer, but it's not really used as a screening test alone and shouldn't be done as so. There are other blood markers. That means where you can do blood samples where you actually look at certain DNA signatures or breast cancer signatures in the blood. All right, such as the masto check or what we'll talk on later on, the multi-cancer early detection test. Well, breast cancer screening uptake is low. We mentioned only about a third of Singapore women actually do follow the breast cancer screening guidelines, as opposed to 75% in the US or even 80% in some European countries. The third cancer I'd like to move on to, which is also a major burden in Singapore, is lung cancer. And this is a cancer that can be improved in terms of screening as well. Although there is no real recommended screening uh, guidelines or specific guidelines per se in Singapore that needs to be followed accurately, and is also not covered by the national health system. But it's important to know what is available outside as well. So more than 60% of patients are actually stage 4 diagnosis. As similarly to all the other cancers, the later the stage, that means the bigger the tumor is, the more it spread to other areas, the poorer your prognosis is going to be. That means your survival is actually going to be much poorer the later it's discovered. Um, we have a College of Radiologists in Singapore that did some recommendations in 2019 about patients who smoke heavily and in the 55 to 74-year-old group. These patients should be considered for screening CT scan, that is a low-dose CT scan, right? There can be some other factors to take into consideration, such as a patient with a female, with non-smoker, and is East Asian, that means Chinese, or a family history of lung cancer, or a history of prior exposure to radiation or carcinogens or air pollution, things like that. So what is low-dose CT? People are worried about CT because of the risk of radiation causing cancer in itself. Well, that may be true. So low-dose CT is a technique or technology where we can do a lower radiation dose CT and see similar sort of useful image quality. Maybe not as good as a full diagnostic CT, but good enough for screening, right? And the dose of exposure is about, what we call as millisieverts. It's about maybe 6 months of the average background radiation a patient will receive in their life. Right? And that translates to approximately lifetime cancer risk of 0.3 to 0.1% for annual screening. But of course, it depends on the age, whether the dose of the CT scanner, how often you do it, and the gender as well. So what's the value of early lung cancer screening? Yeah. Um, so we have multiple trials run in different countries, not in Singapore. There's one running in Singapore at the moment, but it's shown that when you do screening, for example here, right? This 1A means the earlier age group, the very small tumors, right? And the blue represents the screen arm. That means 50% of the patients being screened will be diagnosed with a very early stage for small tumor where it can be easily treatable, very safely, very cheaply. Whereas if you do not go for screening, that means the green or the red 50% will actually be diagnosed with metastatic, that means stage 4 is spread to other organs as well, where the treatment is more difficult, prolonged, lifelong, and there's no survival. Yeah. So screening helps reduce the mortality of by 25% in certain groups of patients. Yeah. And in Taiwan, which is maybe the closest to Singapore in terms of race buildup, um, when they started screening in 2024, they detected about 2.6% of lung cancers in the screen population, and out of which 78 or close to 80% will be in the stage 1 stage, right? The screening was actually also very sensitive and very specific, although it's important to take note of the positive predictive value. That means everyone that's been screened for lung cancer, they detect something suspicious that's considered positive. Only 14% will actually have lung cancer, right? So screening guidelines are mainly based on smokers. But it's important to note in Asia, it's maybe a different story, especially in the female population. So if you look at Singapore, right, Singapore being this one here, in the female population that were diagnosed with lung cancer, only 10% are ever smokers. So if we base our guidelines based on smoking alone for females, we would have missed out 90% of them, right? Only 10% are ever smokers, right? And so if you look at the CGH audit, Changi General Hospital audit as well, across the whole population, only one third of the patients are actually non-smokers. Yeah. And if you base on the guidelines, okay, heavy smoking 55 to 75-year group, then you do CT scan, more than 60% of the lung cancer patients would not meet these guidelines, right? So other risk factors should be considered, family history, you know, age and things like that, right? And this is especially so for young women. So I feel that our tolerance for doing a CT scan in younger females with some symptom or some family history should be tweaked a bit, where we will have a lower tolerance to do CT scan. So next we move on to multi-cancer early detection tests. So what is multi-cancer early detection test? This is fairly novel. It's come down in the past few years, recently only, right? So multi-cancer early detection test is based on what we know as liquid biopsy, which tests the blood and sort of tries to biopsy the tumor, right? And it aims to screen for undiagnosed cancer, right? It uses AI algorithms to test for the origin of cancer and to read out for cancer signatures. And the cancer signatures can be based on such as the DNA of tumors or some proteins, or that, or even the cells of the tumor that is circulated in the person's bloodstream. And with that single blood tube, you can even look out for 2 to even 50 over types of tumors in that single test. So what is this circulating tumor DNA technology that's applied commonly for this multi-cancer early detection test, right? It's actually not new. It's actually been around, where we do it in pregnant females, where we test their blood for genetic abnormalities in the fetus, such as the non-invasive prenatal testing. So that's been done very commonly in Singapore already. So it's a similar technology where we take the mother's blood, test it for genetic mutations in the fetus itself. So similarly, in this case, we take the blood from a patient and we test for tumor DNA in the patient itself, right? So how is that different from screening? Yeah, well, it is a blood test, so that means there's no radiation exposure compared to some scans. Yeah, it's easier to do. You can do it at the GP clinic to take blood. You don't need to go to a hospital or some specific scanning center to do scans. So it's accessible. And the other thing is also important to note that it's also quite accurate and it's also affordable than doing like multiple MRIs and things like that, right? But important to note, it is new technology. So how does it compare to the other technologies available that's commonly done in cancers? So I'll use spot mass as a sort of one of the commonest tests in Singapore that's being done, right, for early detection. So spot mass test actually detects 10 types of cancers from a single blood tube. Um, there are other tests available, such as the gallery and things like that, that actually do 50 over. But each of these have its own sort of characteristics and specificities or, accuracies. So, for example, if you look at spot mass and you look at sensitivity, the reported sensitivity of this test, right? So, spot mass is around 80% sensitive in picking up cancers, whereas something like this will be 50%. But all these are still better than the tumor markers that are normally done in terms of the packages, such as the CA or the CA99, where it can be as low as below 10, right? Uh, how about specificity? That means if the test is positive, how likely is it that you have a cancer? Well, it's almost 100% in all these DNA tests, right? But um, the positive predictive value, which is actually very key. That means if you have a positive test, does that mean you have cancer? No. So in spot mass, it's 60%. In some of the other tests, MCED tests, the ctDNA tests that are done, it's actually not been reported because they haven't done the big trials. Tumor markers such as the CAA is as low as 5%. Even mammogram, when you have something detected in the breast, it can be as low as mammogram, can be as low as 5% as well. Yeah. So the positive predictive value is very key because the higher it is, the more likely the test is more accurate. Yeah. So spot mass is one of the higher ones available currently. So spot mass detects different types of cancers, such as the 10, but of course, it has different sort of sensitivities for the different tumors, right? It is validated in more than 10,000 patients. That means they've actually run the test in more than 10,000 individuals to actually get the real world data available. So that's very key in terms of deciding, as a clinician, what test I feel is reliable. And it's also important to note as well, it's also not 100% accurate. For example, in the stomach, it is as low as 61% of being able to pick up a cancer in the stomach. So it's important to look at symptoms and individual risk factors on top of doing this blood test alone in terms of determining whether we should pursue further in terms of investigations for our patient as well. And spot mass is also helpful in determining picking up precancerous lesions as well, because it actually looks for DNA changes in the bloodstream. So applying this technology, newer technologies, helps increase earlier detection, reduce false positives, detects pre-malignant conditions, and address some of the sort of limitations in terms of accessibility, affordability, things like that, and has the potential to increase survival. Yeah. So in summary, the cancer is a major health burden in Singapore. 1 in 4 will get it. There are screening programs available, and that can help in terms of earlier detection, but it needs to be done regularly, 2 yearly, 1 yearly, 3 yearly, 5 yearly, depending on the screening test done, right? There are many different screening tools around. Some are standard, some are non-standard, but doesn't mean it's not helpful. Some are based on imaging, that means radiological or radiation based. Some are blood based as well, and each has limitations and risks. We also talked about the multi-cancer early detection test, which some of you may be wondering about. What's this 50 tests of 10 tumor types that can be done? And I hope with this you've understand it a bit better. But this test important to note, this test do not replace the national guidelines that are available. That means if you do this test doesn't mean you don't need to do your mammogram. You still need to do your mammogram. You still need to do your stool test or your colonoscopy, and you still need to go for your pap smears or your HPV test. But it's meant to supplement and give further information to the clinician in terms of deciding an individual's patient risk for the test. None of these tests diagnose cancer, but it's the investigation that points to whether we actually need to diagnose cancer through a biopsy or further investigations as well. Yeah. So in summary, early detection saves lives. Regular screening is important, and it's one of the steps for you to stay fine. With that, I thank you, and I'm happy to receive any questions. And I'll hand over the mic back to Bina. Thank you.
Thank you, Dr. Chia. So we will now begin our Q&A session. If anyone has any questions, please feel free to share them in the comments and we will address them accordingly. So while we wait for people to start asking their questions, I have one question of my own. So you shared about this multi-cancer early detection test. So how much does one test cost? And who would you recommend to do such a test?
Okay, the multi-cancer early detection test, the cost uh, depends on the individual clinic and the type of test being done, right? There are multiple sort of companies available, like I showed, and each has a different sort of price point where it can be in a few thousands or it can be the below 1,000 range.
Mm.
So who can do this test is actually the GP, or even like me, I do cancer screening as well. So any doctor is actually able to do this test if they have it available to them or the resource is available to them. Yeah.
But in terms of like the age group or any risk factors, does the person seeking medical help have to initiate and ask their
So
doctor, oh, do you have this test
yes,
available?
yes,
Or
they
like,
do, because these tests are not under the national guidelines. That means
mm,
they are not recommended per the national guidelines. Uh, because the national guidelines looks at population-based cost effectiveness as well,
mm,
which is very important to help lower the cost burden of our health economy, right?
mm,
And also, these tests are all new, so we need actually more data to show the survival benefit. But so far, it
mm,
has shown to help in terms of earlier detection. Yeah. Um,
mm,
so uh, it takes the individual to actually approach the clinic, the physician, to ask for this test. Otherwise, without the knowledge, they may not. The physician as well can sort of bring up this test, or they may advertise it and such. Yeah. So who should go for this is it actually depends on the individual risk. For example, as I recommend some of my close friends to do this test because we are a bit more kiasu lah in a way, right? So it really depends on the individual risk appetite lah.
mm,
It's the most important thing to note is this test to not replace the national guidelines, which was shared earlier.
mm.
Yeah.
Okay. Thank you, Dr. Cha. So we have started receiving questions, so just go through them individually. So we have a question from Carol on PET scan. So I guess she might want to understand more about like the benefits or any disadvantages of doing a PET scan for screening.
So, oh, okay. I do not recommend a PET scan for screening per se, unless you have some sort of tumor marker that's persistently elevated and they cannot find out where it's from. So, PET scans are actually used in terms of staging a patient that has
Mm,
already been diagnosed with cancer. PET scan actually carries it's a whole body scan. So the CT radiation dose. On top of that, they add a new sort of a radioactive substance into your body to sort of pick up cancers better. So the radiation dose from a PET scan is actually significantly higher than the CT lung that was mentioned just now. So I do
mm,
not recommend it as a screening to be done regularly. But only in the individual that has already been diagnosed with cancer, or we're actually really hunting for where this why the tumor marker is persistently elevated, like where, to sort of get a better understanding of the patient's situation. Yeah. Yeah.
Mm. Okay, thanks for explaining. So it's more of like a follow up after you get like a positive screening and a positive biopsy uh, result.
Yes, correct.
Mm, okay. And next we have a question from Shanshan. So you mentioned that people are getting cancer at a younger and younger age, but like according to these national guidelines, uh, they only sort of target people between like 40 to 50 years old. So uh, should people, younger people, go for like specific cancer screenings at an earlier age, in your opinion, or should they like would just like a blood test for a cancer marker be sufficient? I guess this more in the context of if younger people start doing health screenings uh, on their own, should they also, like request for all these screens to be done?
Yeah, so I think our guidelines are actually pretty good in that it takes into consideration the individual risk. So, for example, yes, it's rising particularly in Singapore. I'm not talking about in the Western nations or some other countries, but um, particularly in Singapore, there is a slight increase, lah, to be honest with you,
Mm,
especially in the female younger age groups. Um, should the national guidelines change? Well, that depends on the data that the government will take to sort of change the guidelines for them. Personally, I think why it's important to know that in younger patients, the risk of cancer sort of is increasing. How we should help ourselves is that to become more aware, and also for doctors and to be more aware that in younger patients with chronic symptoms that are new, like for example, persistent back pain,
mm,
persistent cough. It doesn't always mean that it's because of infection or allergy or some muscular thing. I think it's important now to know that um, cancer can happen in the younger age group. So um, to do the right test, or sometimes or to have your radar high up for such things is there important. So for a younger patient, let's say if you are 30, without any family history of breast cancer, I don't think you should do particularly any screening. If you're 40, um, yes, you can do screening if it's safe and done correctly. What do I mean by safe? Safe is like blood tests. I think blood tests are fairly safe as opposed to CT scans or things or PET scans, things like that, because there's no radiation involved. So those blood tests may be helpful, particularly the cancer detection, this MCED,
mm,
because
yeah.
the false positive rates are lower and the positive predictive value is actually better. That was more accurate than the routine protein-based ACA25 sort of tests.
Mm, okay, thank you.
Yeah.
And we have a question from PH Loy on their exit ray results from a few years ago. So I guess please seek your medical advice from your own doctor. We will address the other questions on screening tonight. Right. So from Ishan, she suggested, or maybe asked, if the government's institutions should at least make one of the cancer screenings compulsory, like maybe colorectal cancer, since you mentioned it's like one of the top most common cancers, but there's only like 20+% of people who follow these guidelines. What do you think about this?
Yeah. Well, everyone is actually a freedom of choice, lah.
Mm,
Um, oh, it's a tricky question. Uh, yeah, yeah. Actually everyone has the right to whether they want to be screened or not. People who don't go for screening, they take the risk, and it's their right to take the risk because they maybe
mm,
priority is different. So it's hard to impose a strict because it only affects the individual. It doesn't affect the population, not like vaccinations, things like that, where it affects the entire population, right?
Mm,
So for screening, it only affects the individual. So it's not right for the government to actually impose such compulsory
mm,
measures on the individual.
mm. And I
Yeah.
mean, on this note, on colorectal cancer, what is the difference between a stool test and a colonoscopy? Like, when should people decide when which one they should take? And yeah.
Okay. So the colonoscopy is gold standard, right?
Mm,
But the stool test done regularly and sh- is close enough lah, to a colonoscopy gold standard
mm,
test.
okay.
And it's much cheaper and safer in a way. So with colonoscopes, you have to prep. That means you have to clear your bowels, you have to adjust your diet for a period of time. You have sedation, admission, the costs involved, things like that. Whereas the
Mm,
stool test is so easy, you just collect your stool. So there are pros and
mm,
cons to each. Gold standard is colonoscopy done every 5 years. Yeah,
okay.
because the sensitivity is so much better than a stool test at picking
Mm.
up precancerous lesions as well.
So, is there a difference? Like, if you do a colonoscopy, you find like a tumor in the colon or the rectum versus like in some other part of like which location of the
Yeah,
tumor that does it
yeah. So
affect?
the colonoscopy can tell you where along the colon there is some abnormality. They can pick up
Mm,
polyps. You know that small thing
mm,
in the previous slides. They can
yeah.
pick up polyps. Whereas the stool test, the chance of picking up polyps is, I think, less than 50% of picking up precancerous lesions. Yeah.
Mm,
So it's actually very important to pick up precancerous lesions as well. I mean, a single stool test, if you do repeated, probably better. But it's important to
mm,
pick up precancerous lesions because if you remove a precancerous lesion, it will never become cancer. There's no risk of
mm,
spread. Even a small cancer can spread. You get what I mean?
mm, correct.
So the colonoscopy has that benefit.
Mm. So, like, does the location affect the person's prognosis?
Yes. So it affects whether it's the colon or the rectum, which
Mm,
is lower down the colon nearer the back passage of the anus. It does
mm,
change the management of the patient
mm. Okay.
and the type of
So, like,
surgery and the significance of it. Yeah.
so the colonoscopy would be able to provide the doctor with such information
Correct. On
and
top of that, the
do, yeah.
colonoscopy will be able to biopsy the lesion at the same time.
Okay. So, like, if you do a stool test, then later on they will still need to do a colonoscopy to check
Correct.
where it
Correct.
is and do the biopsy. So, yeah, okay.
Yeah. But there are just the inconveniences as well as the costs and the risk of colonoscopy that one should take into consideration.
Okay. Thank you. And so, like, is a biopsy always like 100% accurate in confirming a
No,
cancer during screening?
no, it's not. It is also not. Unfortunately, it is the gold standard, but it's not
Mm,
100%. Because there are misdiagnoses, whatever biopsy is done, it's all still, uh, there can still be human error or processing error, things like that.
mm.
Yeah, in terms of a biopsy.
So,
Yeah.
when would a patient like really know they really got cancer? Like after
I mean,
screening, the
oh no, I mean the
biopsy?
biopsy is the gold standard, so it's like almost 90 over percent,
Okay.
definite. Yeah,
Mm. Okay, so it's like not perfectly like accurate because of other reasons.
yeah, but
In
smaller reasons, but it's
yeah,
actually the
okay.
most accurate.
Okay. So Ming Hui asked about prostate cancer, which we didn't really touch on during the talk.
Yeah,
So is PSA
yeah.
monitoring on a yearly basis sufficient? And what about, is there a screening method for pancreas cancer,
Yes.
two
So
different cancers?
prostate cancer PSA screening is pretty good because it is actually it's been shown to be helpful in terms of early detection as well as saving prostate cancer lives. But um, there are a lot of false positives with PSA, and a lot of prostate cancer patients actually do not die from prostate cancer. So there are some pros and cons to each. So it's important to know them when deciding. But the PSA itself is actually very good because almost 100% or 90 over percent of prostate cancer patients will have a PSA. But the PSA screening should, the cutoff level varies
Mm,
because an older patient may have a higher cutoff level, whereas a young patient will have a lower cutoff level, things like
mm,
that. And the PSA screening, in my opinion, personal opinion, should especially be done in anyone with a family history of prostate cancer. Yeah, and I
okay.
also feel that it's actually not done enough. Um, uh, yeah, especially in Singapore as well, because a lot of males
Mm,
have urinary symptoms and attribute it to age,
mm,
and they just live with it until it becomes something else. Then they
mm,
realize that actually it's prostate cancer or later stage prostate cancer, and they don't. And actually, if they had not attributed to age alone, and they had seen a GP or something like that, and get the PSA done, then they may have already pointed to a certain direction in terms of a treatable prostate cancer.
mm. So if they
Yeah.
don't have any symptoms, like what age does the national guidelines sort of
So in the
recommend for?
US, we don't have a national guidelines for PSA screening, but in the US, it's actually a 50 or 55, the PSA screening.
Mm, okay, 55. But in Singapore, there's no such guideline. Uh,
No, yeah.
okay.
There's also a race uh, uh, predisposition. For example, in the US, the uh, Afro Americans actually at higher risk. That's why maybe they have that need there more so than in
Mm,
Singapore. Yeah.
okay.
So, but I think if cost is not an issue, I think PSA screening should be done regularly.
From which age? 50? Uh,
Uh, yeah, I think from 50 would be reasonable.
okay. So what about pancreatic cancer? Is there any like screening method for that?
Yeah, pancreatic cancer is usually screened using ultrasound MRI as well as CA19-9, and
Mm,
especially the case in patients with a family history of pancreatic cancer. That
mm,
should certainly be done. Uh, mm, that's how we screen for pancreatic cancers, actually. Yeah.
okay.
Of course, this MCED test is also can be helpful in terms of screening for pancreatic cancers.
Mm, okay. So I
But it's
guess
not
that
routinely done across the general population because the risk of pancreatic cancer, although it's one of the most deadly cancers, it's not one of the most common cancers, top 10 cancers.
mm, so I guess that test that blood test that can test many cancers, the doctor will usually assess the patient or that person's disposition and risk factors before recommending
That's
which
right.
specific
That's
cancers
right.
to test for,
Yeah.
right? And that's why the
Yeah.
cost would like vary depending on their
That's
risk
right. The cost
factors.
varies
Okay.
significantly
Mm,
based on individual risk factors and risk tolerance, not just risk factors. Everyone may have zero risk factors, but a patient may have no, like they really want to know early on, and it's their
mm,
right to know early on. So it's an option,
okay.
an individual's option. Yeah,
Mm,
choice.
okay. Thank you. And then now moving on to breast cancer. Shan asks that some men might also be at risk of breast cancer. So uh, when would a doctor recommend a male patient to go for a mammogram to screen for breast cancer?
A male won't go for a mammogram because basically you cannot. The mammogram requires you to sort of squeeze the breast, for.
Oh, okay.
Yeah. So MRI is a good alternative for males. For in the maybe the those with a genetic mutation such as a BRCA mutation, to
Mm,
go for screening. There is no actual real specific guidelines uh, in terms of age cutoff, but probably 10 years before a diagnosis, maybe a family member with a diagnosis you can consider.
mm.
Um, yeah.
So this BRCA mutation, is it like hereditary from like your female part of the family? Like so maybe your mom has that
Yes, it can be
mutation. Will it
hereditary.
also be? Okay, so even the sons might also be at risk of getting such a mutation.
Yes, yes,
Okay.
yes.
Mm,
And BRCA is not just related to breast alone. It can be related to like pancreas, prostate,
mm,
ovary. Sorry.
okay.
Yeah.
Uh, so, is there a difference between doing a mammogram and doing an ultrasound in terms of picking up cancer?
Is there a difference in terms of mammogram and ultrasound?
Mm,
Yes, very different.
w-
Ultrasounds
mm,
are not really used for picking up cancers. They're used to. Okay, no, sorry. Um, they're actually complementary, lah. If you were to say,
okay.
yeah, especially with younger females with very dense, or Asian females with dense breasts, where the mammogram looks at shadows. The ultrasound actually is very helpful in terms of picking up uh, tumors in the breast or to
Mm,
clarify some of the shadows. Yeah.
okay. But it's still recommended to do the mammogram, and then the ultrasound is like a
So in the
complementary.
younger females, less than 40, if they really need to do screening, it's actually an MRI that should be helpful. Yeah.
Mm,
But of course,
okay.
it's not always available and things like that. So an ultrasound may be can be an alternative, not the gold standard. Yeah. And those between 40 to 45 is usually a mammogram should be good, plus the addition of ultrasound to sort of add the clarity. After 45,
Mm,
maybe a mammogram, the breast is not so dense already, so you can do the mammogram alone.
okay. So, let's take one last question before we end the session tonight. So, I think you already covered like the lung cancer, like sort of screening guidelines, which are not really like available here. But what about liver cancer?
Okay, sorry, not that they're not available, they're not covered by the National Health Screening Program.
Ah, okay.
You can
So
go to
there's
your
no like,
doctor and ask for health screening, lung cancer screening, but of course, take note that there is radiation risk in terms of CT scan. So the doctor has to
mm,
decide based on the individual risk profile, but whether they want to, whether they would recommend it or not. But there's no
mm,
sort of covered screening program in a way for
mm.
lung.
In terms of insurance and government
No, I
subsidies.
don't think screening
Oh,
programs are not covered by insurance, but in terms of health subsidies and things like
I'll
that.
have subsidies. Okay. How about liver cancer in terms of like screening? How old or any
So
risk
in terms of
factor?
liver cancer, those with chronic hepatitis and or liver like alcoholic liver disease, things like that, fatty livers, um, you should do screening
Mm,
for liver cancers, being an ultrasound or and the alpha fetoprotein. These are the liver tumor marker.
mm.
Yeah.
And at what age?
The
I
moment you
mean,
are
when?
diagnosed with chronic hepatitis, it should be done
Okay.
already every
Okay.
few years or every 6 months. Sorry.
And if you don't have any symptoms, should
Then
you?
no, there's no recommended screening guidelines for liver cancer if you don't have any risks.
Okay. So, thank you, Dr. Chia, for answering everyone's questions, and thank you everyone for your participation. So it's now time for Dr. Chia to take his leave. Once again, thank you very much for sharing your insights tonight. Do like, share, and follow us on our social media pages for the latest updates of our events. Once again, thank you very much for joining us tonight. Take care, stay healthy, and good night.